All right. Hey, everybody. So to close out our panels of the day, before we see the HHS CIO speak, we're going to get into a little bit more about the data management at some of these agencies, and as well as the security issues that come with that. So we know who these guys are. Let's open it up with more of kind of a general question just to break the ice. What are some of the data management challenges that government is faced with today in the healthcare space? And we'll start with Robert.
Thank you, Amy. Good morning. My name is Robert Owens from the Department of Health and Human Services, Office of the Inspector General. And our mission is to protect the programs at HHS. And to do that, we rely heavily on data across the organization. So one of our challenges is to A, access that data, and B, make sure we secure it. And that we'll talk a little bit more about that during the panel.
Jeff.
And I'm Jeff Grant. I am effectively the COO of healthcare.gov within CMS. And I would say the general challenge you face in all data spaces is the ability of the business to be able to communicate adequately with the tech experts so that tech solutions actually are targeted toward the business needs. I feel there's always this kind of conversation of talking past each other where the business is insufficiently tech savvy and the tech side is insufficiently business savvy that leads to unsatisfactory solutions at times.
Jason.
Good morning, last but not least. So Jason Glanville, Director of Product Strategy for Project Special Forces at Veterans Affairs. So specifically within the Lighthouse API program, we're looking to actually make data enabled, open, and yet secure to help drive technology innovation within our sphere.
All right. So with Lighthouse being the VA's execution of the open data strategy, how is it meeting the agency's goals with regard to how you are delivering care to veterans?
So a critical part within healthcare is not only having the continuity of care and a consistent care plan across a distributed healthcare system, but a key component also is empowering the patient to be part of the conversation, to be part of the decision-making, the consultation, to be aware of what's going on, especially as healthcare becomes more complex, with advent of new medications, new technologies, new value-based care models. And so the Lighthouse API program, the health API that we have out there, helps provide digital access to our veterans that they can then access and securely share their information with trusted technology partners to help to set, manage, and achieve their own goals.
And Jeff, you mentioned your data strategy is part of the overall IT modernization strategy at your office. What is that strategy? What is its aims?
Okay, sure. It's kind of odd when you think about us being having stood up a system in 2013 for a launch in 2014 that we're already talking about a modernization. But if you understand how we were born, you would understand why that is necessary. This was a huge endeavor to set up an eligibility process. It was the first one for CMS. CMS gets eligibility for Medicare from SSA. They get eligibility in the Medicaid side. The Medicaid states do it. They're aware of what happens there, but they don't actually actively manage eligibility processes. Then you have an entire enrollment process. You have a number of complicating factors around not being a federal health insurance program and doing a whole bunch of operations for the first time and building tech to support those. So what you end up doing is you build up what you initially envision, and then you find out what you really need to do, and you keep kind of throwing things onto something that you built that was not designed for this full range of scope that you have. And so one example would be enrollment data. And we knew we had a challenge with it, but we weren't able to work our minds around how to deal with the challenge. But when you enroll people in private insurance coverage through a central entity, you have your own central version of what that enrollment is. And then you send it out to a bunch of insurance companies who interact with these people who have life events that happen, and sometimes those life events are reported to us. And sometimes we're kind of like hotels.com to them. You get your hotel room from hotels.com, but when you want to access the minibar, you don't go back to hotels.com, you go to the hotel. If you want to change anything, you're dealing with the hotel at that point. So you start dealing with the insurance company, and we start getting out of sync. And so we have to synchronize that data. So we built processes to do that, to send files out to them, to get files in from them. That becomes an analytic process that's built to the side of the exchange. And then we have another contractor that deals with all of the fallout from payment. And a discrepancy on payment is actually an argument about the facts of enrollment that led to payment. And they build out their own process, and they start getting the same data files that the reconciliation contractor. We pass those downstream to them to help them understand the world and make sense of payment disputes. And all of a sudden, you start proliferating enrollment data all over the place as you built out different processes out of necessity, but you didn't have this master plan built out when you designed your data model. So we're now looking at our enrollment data model and saying, you know, we've dispersed a lot of data. We could probably centralize it, but we're going to have to wrap our heads around every place this data is used and figure out a strategy that allows everybody to do their business process the way they need to do it, but we can do it in a much more integrated fashion so everybody can see the same facts as they change. So we are invested in a multi-year effort. Some of you may have heard of the MidCap project. This will be a central focus of the MidCap project, is kind of aggregating this data and figuring out how to quit passing files back and forth and actually start communicating with one integrated data repository.
Great. Now, Robert, at OIG, you are responsible for delivering to the overall department data in support of its use in analytics. So how are you strategizing around that?
One of the things we do is, our vision is to drive positive change in the organization. So we try to take advantage of existing resources like the Integrated Data Repository, I think, which you were just referencing, at CMS. So this is a great resource of data at CMS that we do our analytical work on. In addition, we have internal resources to do our analytics work. So a big driver is to reuse shared services that the department offers, and we also have to build internal services, particularly shared self-service tools, to allow particularly our auditors, evaluators, investigators, and attorneys to oversee the programs at HHS.
And I should probably clarify, by the way, I sloppily use the term Integrated Data Repository, which has capital letters in CMS right now. Mine is more of a lowercase integrated data repository because we're not part of the Medicare program, so we actually can't merge our data with Medicare. It's another challenge because of HIPAA and rules on access. People in Medicare can't look at our data because they have no business reason to. So to protect patient privacy, our data is separate, but we will have to build something out similar to what Medicare has thought its way through with claims data. We have to do that with enrollment data, but we will have some form of integrated data repository that will not be the capital IDR.
So one aspect of data management is interoperability. And Jason, how is the VA fostering that aspect, especially in terms of continuity of care?
So there are a couple aspects, one being our EHR modernization, where we're taking our legacy VISTA systems and moving into a modernized platform based on standards-based health data. So we would be able to have an entire ecosystem of FHIR-based APIs, so that way our data looks like any other health system's data versus having a medical diagnosis formatted in one way versus another, and then trying to connect this for some type of longitudinal record. You would then have to react to that customized data and actually build and account for it. Leveraging industry standards helps to provide a level playing field from a data analytics perspective. And through that also is the data transformation effort, which is taking our legacy information and every field, every status that would map to an industry standard, making that standardized. So as an example, the health records API that we launched officially in production in November, it provides up to 10 years of health records for our veterans, and that's 10 years of custom data, custom values, what we thought was pertinent field information or value 10 years ago. Who can remember? So there was a lot of effort across multiple partners to make that data Argonaut compliant for DS202.
The power of APIs.
Exactly.
Can you go into how partners are vetted into that program?
Sure. So for our developer portal, quick plug, developer.api.gov, anyone can go there and connect. Go for it. And within the portal, you can request a key. This key for the APIs is for our sandbox. So the first part of the vetting process is to connect with our sandbox, which has synthetic data, which was provided by the MITRE Corporation. So it's truly synthetic, meaning that it's modeled after real-life scenarios, real-life people, but it's fake data. But that way you actually have quality data to work with. So the potential partner has to go through integration with the sandbox to prove their business case, their technology innovation, their model. And once they're ready, they can request production access, which requires a product demo to VA to prove their case, to show their API security in place. And at that point, if all the checkboxes are ticked, at that point they can get production access to the API.
So that kind of goes into the security aspect a little bit to discuss the other side of this panel, security. How is the Lighthouse program managing the security issues that come about some of the data management challenges?
Yeah, so there's the idea of open data and to help provide technology innovation, but open data doesn't necessarily mean that it's completely open, that anyone can see it. So we do have APIs such as facilities APIs. Anyone can connect to the facilities API to see what's the address, the times, the hours, the contact information for a VA facility. That's just open to the public. It's the yellow pages. However, the other side, such as PII and PHI, that is basically open data with consent. And so there are several layers of security that we have. One part within the platform itself is that our platform has the API gateway, which helps to monitor traffic and connection points, but also the platform is containerized. So it's not just one flat environment that if it's compromised, it's compromised. It's containerized, so that way we're able to isolate individual events. It helps to actually provide scalability for organic growth and adoption and spurts for performance and resiliency. But in kind, it also helps to control security risks at that point, because we can shut down a zone, we can shut down a container, and while anyone else who is valid and doing good things can still be connected, but we can isolate nefarious people or entities. But then at the same point, we have several layers for the keys. So when you have your production API key, if I'm a developer and I am connected to the production API, especially a PII or PHI API, that is a lot of I's in one sentence, which is very difficult. I should be proud that I did that on one cup of coffee. Just because I have production access, I still can't see data. I cannot see veterans' information. I have to obtain explicit veteran consent for that particular technology solution. So if I was technology component A and I wanted to provide this solution for a veteran, whatever the use case may be, and I have production access, I can't see anything until you provide consent, and in kind for technology provider B, they still can't see anything until you provide consent and you provide consent. So it's based off of an additional layer of access keys on the individual veteran for that particular technology solution, and also with refresh tokens and expirations, similar to health plans where, when you connect to your patient portal to see what type of claims and benefits that you have, and if you don't log into it after 3 months, you have to then re-authenticate. You have to re-authenticate as well, and that's the part within the individual veteran consent. We leverage the OAuth 2.0 security protocols to actually validate, the veteran validates that they are who they are and they are providing consent.
Robert, you mentioned a data catalog that you are working on. Go into that a little bit and how security is at play with it.
Sure. So one of our challenges with working with the department, which I think is 1.8 trillion in outlays, is there's a vast amount of data behind those programs, and the program owners have that data, and we need to gain access to it. So the first thing we did through the efforts of our Chief Data Officer, Carol Prismakowicz, is she set up a data operations group, and they do the unglamorous work of capturing the data, putting the data catalog together, and making sure we have the security controls in place. In addition to that, we have set up an engagement committee. And what that does is it's just a process that anyone can set up. And through our 4 business units, our auditors, our evaluators, our attorneys, and our agents, the senior leadership comes together. We review work prior to it being engaged in, and part of that review is the data that they will need to do their work. And through that process, we can make sure, A, we have the data. If we don't have it internally, we can gain access to it externally. And this has been a great help for us to not only identify the data we're going to need, but make sure we have the appropriate security controls, because we also have all the I's, but we also have the law enforcement component too.
Jeff, so as a relatively new CMS enterprise, you have a unique data set in operation. What challenges do you face in going from a startup to a more mature data platform?
I think when we built it, some of the challenges we face now, we built a platform that is kind of a tangled mess of code because it was thrown together really quickly. And then again, a lot of things I would characterize as kludged onto it. So each one was kind of as something came up, you built a solution for it because you didn't have time. So it's really disentangling yourself from an existing code base and re-architecting it while maintaining stability. So, one of our primary driving directives is every year we have to deliver open enrollment. So you go through a phase of figuring out what kind of changes you can make that will move the program forward. And you actually may take a year where you're making a bunch of changes and none of those get exposed to a production system because it's the pre-work you're going to need to do as you convert everything over. So we went through a process of converting all of our eligibility to APIs from a tangled mess of like the website interacts directly with the services, directly with the database. Now we have a website, an API layer, and a data layer. We still do not have all the use cases for the application built into the streamlined application. So we got, I think, about 70% of people through the streamlined application this year. The year before, it was fewer than 50%. So those APIs have been out there for a while, but then you have to build your way into using them while maintaining your existing system until you are completely over the hump, because otherwise you're trying to do a massive switch and you could cause massive disruption in open enrollment. So it's trying to deliver the quality enrollment experience and improve it every year, but not take away what somebody already has.
Okay. Jason, so with open data, that presents its own set of security concerns. Discuss how your team is approaching that.
So I probably answered the question previously, but so within open data, it is the idea of what the data is itself. So it's the applied use case and the object of what that data answers. And so facilities information can be open data. It doesn't harm someone. It's information that's just open in general to the public. But having the like PII, PHI information available from an open perspective, a good way to have an analogy is it's similar to being a realtor and having an open house. It means it's open to the public, but you still have to go through a door. It doesn't mean that you knock down all the doors and all the windows and anyone can just breeze through and steal everything. There's still security measures in place that are protecting the house, and it's by invitation that you go in, to make sure that, the realtor is making sure that no one is going through and stealing something or trying to do something. So it's a more curated sense of what open data truly means from that perspective.
I guess this is more of a general question as well for anybody to jump in whenever they would like. Why would you sacrifice security for efficiency?
Never. I think that you have an obligation. I think this is, I can talk more in a little bit later on some of the things we're doing with the private sector, but one of the things I've found in dealing with the private sector and trying to get them to a place where they can access our data is their concept of security is not the same as what the government has. Their concept of quality of delivery is not the same as what the government has. They'll throw something out there, and it's a different model. It is what it is, but if you're downloading apps on your iPhone, you should probably be aware of this, that they do not have the same security standards you're used to dealing with. They don't do ATOs. So we have the responsibility to protect the security and privacy of the data. We are dealing with FTI, federal tax information. There are very high security standards that deal with that. We cannot compromise those. Legally, we cannot. If we were, There are criminal liabilities for that, but it's also just like, forget the criminal liabilities. You have a responsibility to the consumers whose data you've brought in. And CMS also has the Medicare program, the Medicaid program. We have over 100 million people's data. And this is really sensitive data. So the first priority is to take care of that. I think what you're really talking about is not efficiency versus security. It's more like having a risk-based approach to security where you're trying to move the business forward, but not unnecessarily jeopardizing data. We can't live in a world where we lock everything down. Because we have to, you're opening up to the world. There is a risk that you're taking on when you do that, but you have to be very smart about that risk. So you can't be afraid of taking risks, but you cannot be neglectful of security in taking those risks.
Right. Well, and also to that point, from the risk-based decisions that we would make for a trusted partner, as we're going through the product demo, or as they are going through the product demos to prove to us, like to VA, why this is a valid solution and use case, and here's our security protocols in place. I mean, there are a couple areas within, healthcare law, the Privacy Act, a patient's right to their own information. So technically a patient can share their information with whoever they want. From a legacy perspective, I can print out my health records and, well, of course, once they're on paper, everything's dead. But I could go into the street and throw it up in the air because for myself, I don't care. I mean, I'm 6'2"-ish. I'm fat, pre-diabetic, big whoop, but I don't care. Other people, it's sensitive information, so it's in a case-by-case perspective. However, we are still the stewards of veterans' data. So while we are empowering our veterans to be health data consumers in this new consumer direct data exchange, to your point, if we think that a potential partner has an ulterior motive, or potentially they do not have the best in practice security, we will provide feedback and say, well, you would need to make these changes in order to be connected to us truly. So it's part of the open dialogue. It's not so much that we even have like a flat yes or no. It's the dialogue to help also shape this new evolving technology ecosystem where the patients can now connect to their data and do something with it versus just printing it out. But we also have to be stewards for them as well.
And it's interesting you're talking about the balancing. I think, we're running a business here. We're trying to get millions of people enrolled in private health insurance, and we're trying to be as creative as possible so that we can make it as accessible as possible. You're balancing the obligation to allow people to have access to their information with the obligation to keep that information from falling into the wrong hands.
Right.
We're balancing the obligation to get people enrolled and open up as many channels as possible with the obligation to protect the information that we hold. So this is a constant balancing act that we have to take on, and that's why we proceed carefully. But we're also proceeding, it sounds like you're proceeding aggressively, I feel like we're proceeding aggressively, but not recklessly. And you really have to be conscious of not being reckless with it, but not being afraid,
right.
and being in the old world from the 90s where everything was locked in a fort and nobody could see it, because that's not our world now.
Right, exactly.
About 80% of our work involves CMS, and it's the claims data from Medicare and Medicaid. And we feel like it's extremely important to protect the beneficiaries. In addition, there's organizational reputation. If we can't protect this data, who is going to rely on the reports and the work that we do? So we think it's critically important that once we've received this data, we need to protect it.
There's, I heard a balancing act from one of you. Would you consider it to also be a balancing act?
Not in our area, no.
All right.
I think that's more of a traditional model. And there is plenty of places in CMS where there is a traditional model where you're just, you think about an accounting system or something, you're really locking that down. There's not a transparency requirement there. I think we're in a different world when we're directly consumer facing.
Okay. Let's see, Robert, what are the security challenges that you are dealing with, maybe in a little bit more detail?
Sure. So probably the biggest issue is we are not the system owners. So we, particularly on the claims data, from CMS, which is, as I said, about 80% of our work, we have to ensure we're protecting those beneficiary claims data. So whether that's working within the CMS security domain or bringing that data within our environment, that is a huge challenge because it goes directly to reflecting the integrity of our reports that we issue and our law enforcement actions. So we have to make sure that we enforce those security controls. And we also hold CMS and the other components accountable for those same rules, so we need to follow them strictly.
Okay. So looking into your efforts that you have undergone so far, and maybe looking ahead into the next couple years, what is exciting, and maybe it's not so obvious as something like an API at VA, which is directly impacting veterans, but what is something that is very exciting that is on the horizon that would stem from some of these efforts that the end user, I guess, could immediately see an impact of?
Well, I think our exciting thing is where we've also gone to an API-based process to build out, to build this website, service layer, data layer construct. The service layer is now APIs, which means you don't just have to come to healthcare.gov. So where I've talked about exposing ourselves to the outside world, we've created APIs with a data exchange standard where somebody can stand up their own website, and this is getting back to the old way that private insurance was delivered before there was a healthcare.gov. You went to web brokers, you went to agents and brokers in the insurance industry. And we've had that demand on the table since we went live to go back to that old model and allow the private sector in a private insurance industry to let the private sector do their job and market this stuff and do very niche marketing. This year, but to do that, again, we had to have the same kind of standards. So we have audit standards. We have a set of security controls that we have to make sure that you can pass hundreds of security and privacy controls. And you have to have an independent audit of that, and then our auditors look on top of that, and we'll go back and forth until they meet that audit standard. And then we have business logic, too, because the other thing we have to do is deliver an eligibility determination that people can take to the bank. When they come to healthcare.gov, they know they're getting that. If they go to somebody else's website, they have to have that same guarantee that they're going to get the same eligibility determination. So there's this whole oversight responsibility we have to deliver that. But the promise in this is, if you look at what happened this year, this was our first year that we rolled it out on a large basis, so we just call it a startup year. And in a startup year, 30% of our enrollments came through what we call the direct enrollment process. Some of that is still going back and forth to healthcare.gov, but a good portion of it is directly through the APIs, through other websites. And the consumers that came through that process, we had 45% new consumer traffic, 55% returning through that channel. The overall average for all of open enrollment was 25%, which means if you came to healthcare.gov, fewer than 20% of the people coming direct to healthcare.gov are new consumers. So if you want to talk about the opportunity on the horizon, if you can scale that model and continue to deliver 45, 50% new consumers through this alternate traffic, and this was just a startup year, that actually takes us from a sustainability cycle to a growth cycle, which then offers the opportunity for rate reductions, expanded coverage, that kind of thing. So we see this as a really powerful model that we're using, and we're just getting started with it, and we're really excited about its potential to really deliver insurance to more people than we have been, and in more creative ways.
Yeah, and I think from a VA perspective, especially within the API sphere, for me, it's all about data. So being able to take our data and being able to provide some type of unified platform or entity, this thing, because as emerging technologies come on board, who knows what's going to be out in 5 years? You know, I would never think that APIs would be emergent technology within 5 years is just, you know, industry standard, and then in 5 years, who knows what's after that. But being able to unlock the data so that way our innovators, even within VA, there's a lot of good work across many of the offices across VHA to actually take that data to help improve value-based care models, to provide point-of-care decision points based off of existing data models. But then also what would be interesting is that as we identify use cases and data sets that can also help drive the external technology innovation ecosystem through the Lighthouse Developer Portal, actually see how our veterans as empowered health data consumers consumers to see, okay, well, what are they connecting to? Who are our trusted partners? Who are they coming to? How are they using this data? What do our veterans want? It will also help shape from a bidirectional perspective, not just VA down through VHA to say, well, here's what we're doing, but it's also that conversation back to say, well, these are also the use cases we need that we can see through technology trends to also help shape healthcare from that perspective. So we truly have a bidirectional model of innovating healthcare.
Do you think there are any roadblocks to being innovative in government?
Well, I mean, people laugh,
Not a
but
loaded question.
I think if you work with supportive leadership, no. So as long as leadership is willing to do it. But I think the other thing is, like when we implemented EDE, this enhanced direct enrollment process, we went into the previous open enrollment period, and the bets within the team were somewhere between 3 and 7 partners being live before open enrollment. We didn't hit that. We got 2 live at the very end of open enrollment and like a trickle of traffic through that, so it became, at best, a beta test of a new process. I don't think you look at that as like a barrier to innovation. If you want to innovate, again, you have this responsibility to deliver quality and keep the security in place. If we would have rushed, lowered standards, and had problems as a result of it, the whole project could get shut down as a failure. Instead, we kept the standards up and made people meet the standards, and then we delivered a successful project, and this year the success was demonstrated. So I think you don't need to rush into innovation. You have to be patient with innovation, but you have to constantly work toward it and grind away at innovation. It's a lot of work, but it's a lot of work because of the responsibilities that we have as public servants, not because government itself is inherently flawed, but I think it's the responsibilities that we have to deliver quality programs and to protect data that actually make innovation go a little bit slower, but at an appropriate pace for serving our customers.
Yeah, and I think also it's just the nature of technology, where now technology is moving so quickly, where you even see across educational systems that there are more certificate programs versus actual like degree programs, because technology is moving so fast. There are more light frames of how am I going to be be valid or certified in a specific field. So unless you are an entity that was developed new in this new or emerging world, it's just tech debt. So coming from corporate America across the PBM industry, you have mainframe here, MQ messaging and FileNet servers and legacy web services that were hip and cool back when you saw dial-up and Prodigy.net, and so it's just connecting the data silos and then going through that, and from the connection also making sure that data is clean. It is, someone dropped it earlier today during one of the pre-session, wrangling the data, and actually making computational and making it standardized, so that way we actually have a good sense to move forward. It's not so much an obstacle, it's just the work that has to be done.
And it's quite possible that the APIs we're building today will be the tech deck of the future.
Exactly, because there will always be something new and better to move forward, and I hope so, because we just can't stay stagnant.
Right.
We have to move forward.
Great. So I want to open it up to the audience to see what you guys want to hear. Is there any questions before we move on?
I have one.
All right.
So
There's actually a mic being passed around.
I heard you mention a data model in some of your discussion there. So across the board, is there a desire for a common data model across healthcare or not?
So common data model for the industry or within VA specifically?
Industry at large. I mean, my tears, as I've talked with Colonel Scott in the past, were OMOP versus Sentinel. Drive us to a common model. I'm not saying all data should be structured, but in the structured data that we have, if we talk in a common model, then the DoD and the VA can collaborate better, and I think across the market as well. But that's my opinion. I'm curious what yours is.
Yeah, so that's a really good question, and we need a lot more time for this. But I think so there needs to be some type of common data set, of course, to drive the commonality of data exchange and understanding what that means. So I know like ONC had their final ruling as far as what is the U.S. core profile for information, driving standard fire standards from that perspective. But also at the same point, there are going to be nuances where I think there will be unique data models, especially with leveraging like AI technologies. computers are defining new data models and we have no idea how they derived this new algorithm or what have you, and yet it's a valid key data model and protocol to drive innovation forward. So I think it's both. There's going to be a common data set, but it can't just be a one solution fits all. There is going to be a hybrid solution. I'm always about hybrid. There's always a common path, and then you have to have some sort of flexibility in your approach for things.
And while we're using APIs now and maybe something else in the future, or maybe some blend of things, I think the defined information exchange standard, in the past it was X12, now it's APIs, but having a defined information exchange standard, having data definitions that are common across an industry, get you about as far as I think you want to get, because you don't know everybody's end use of the data. So a data model is always structured not around like us sharing data, but what am I doing with the data and what is Jason doing with the data? If it is something different, then we need to agree on how to exchange it, but we need a data model that is serving the end use of the data. So I actually don't think we should ever have a common data model. I think data models should be centered around end uses, one of which is I need to be able to talk to him. But it doesn't mean that I need to model my data exactly the same as him, because he's going to do different things with it. We don't even have a common data model between enrollment and payment within the exchange, because a payment view of enrollment data is a month-by-month snapshot of like how much do I owe you, and enrollment is a span that you have to convert to a payment view of that same data. So we remodel our own data because we have different purposes for it, but it's all integrated. So it's more the ability to communicate with a standard, I think, that is the most important.
All right. There's one more question.
Name's John Scott. I, until recently, worked at Defense Health Agency. And while there, I was involved in a lot of the collaboration work between DoD and VA and sharing information between the departments and with the private sector. My question's sort of organizational based. In the projects that you're working on with Lighthouse, to what degree are those being coordinated with what I'm more familiar with, which is the My Healthy Vet in the Office of Connected Care at VHA? Because we've been working with them to have interoperability of the patient-facing applications, and we think we're making some progress. But I didn't hear you mention much of what I know to be the capability of that platform.
Oh, so Lighthouse essentially serves as the front door for VA. So as we move forward with EHR modernization, and modernization like with My Healthy Vet and other offices across VA, it's not that like Lighthouse is actually working to build APIs per se, because not one team cannot build APIs for VA. It's really helping to connect the partnerships to say, well, My Healthy Vet has technology, has potential APIs, other systems such as other databases and services would have potential viable APIs in a use case that we can then publish out. So for us, it's more about evangelizing and bringing forth data from that perspective versus us actually doing our own silo of work and then hoping it coordinates with something else, or then we have duplicative builds and everything. So,
That's
you're welcome.
reassuring. Thank you.
So we are out of time, but thank you so much to these guys. Another round of applause for them. This was interesting. Thank you.